All right, well, thank you for coming. My name is Dawn King. I'm one of the urologists at Idaho Urologic Institute, and I'm here with Dr. Parrillo, Lisa Parrillo, one of my partners. And as you can see, we're talking about urologic and gynecologic health after menopause. And we're thankful for St. Al's for allowing us to use the space. And we do have some pamphlets in the back and some cards. So we're going to talk about first, I'm just going to go briefly over some of the urological issues that women face after menopause, and then we'll get more into the gynecological issues, specifically the MonaLisa laser. So what do women face with aging? Well, several things, unfortunately, in the urinary tract. One of them is overactive bladder. Well, what is overactive bladder? It's frequency, urgency, going more often, sometimes leaking with it, sometimes getting up at night. Nocturia means getting up at night, getting up more than you want. Incontinence, and we'll go into this more in depth in the next couple of slides. Urinary tract infections, and prolapse, which means some type of droppage or falling out in the vagina, the bladder, the uterus, even the rectum. So what is overactive bladder? Is it a disease? Not really. It's a symptom complex involving urinary urgency, frequency, and incontinence. Unfortunately, it's very, very common as we age. There's different definitions for some of these urinary tract issues. Urgent incontinence is an involuntary leakage accompanied by or immediately preceded by urgency. I always ask my patients, do you have the syndrome of, I gotta go right now, I can't hold it. As soon as I stand up, I go. I have to know where all the bathrooms are. I leak on the way to the bathroom. Increased daytime frequency is just going too often during the day. Urgency is a sudden compelling desire to pass urine that's too difficult to defer. And then nocturia is waking up one or more times at night to void. There are three common types of urinary incontinence. Urgent incontinence, as I mentioned previously, is just the strong, sudden need to urinate due to a bladder spasm or contraction. Stress incontinence is loss of urine during stress maneuvers, physical activity, coughing, sneezing, laughing, exercise, lifting. Mixed incontinence is the combination of both urge and stress incontinence. And over 16% of the U.S. population will have one or more of these symptoms, urgency, frequency, or incontinence. Well, what are the treatment options? First of all, I encourage all of our patients to undergo behavioral therapy, perhaps modifying your diet. What are you drinking? Are you drinking a lot of soda pop? Are you drinking a lot of coffee, a lot of tea, a lot of things that will irritate your bladder? Are you drinking just too much water? Caffeine can make it worse. Alcohol can make it worse. So we have patients look at their behavior. Pelvic floor strengthening involves referring patients to a certified physical therapist that does pelvic floor therapy. So I tell patients, a lot of them will tell me, oh, I know how to do the Kegel exercises. I've been doing them for years. Well, I think a lot of patients aren't doing them right, and they'll come back to me after seeing the therapist and they'll go, I really wasn't doing it right. And the therapist helped me learn how to do the exercises correctly. They might do biofeedback, which is great. They'll put little electrodes on the perineum or on your bottom, and they'll make sure that you're able to recruit the muscles that you need to make yourself stronger. There's lots and lots of medications for overactive bladder, and you've probably seen these ads on TV. They all want your business. Some of these include oxybutynin or ditropan. Detrol is an older one. Vesicare is a good one. Enablex, Cinctura, Toviaz. Myrbetriq is one of the newest ones. There's a couple meds that are in the form of a gel. One's called Gelneek. And then there's a patch that came out on the market a few years ago. You don't actually need a prescription to use the patch. It's over the counter. It's used twice a week. It's called the Oxytrol patch. And Gelneek and Oxytrol are both oxybutynin in a patch or gel form. So if medications don't work and if the therapy is not working, then we might go to more advanced therapy, which would include some type of sacral nerves, some type of nerve stimulation. So that involves putting in like a little pacemaker device in your backside above your tailbone to help control your bladder. And there's another type of stimulation we do in the ankle. It's called posterior tibial nerve stimulation. And that is a once a week for 12-week stimulation, and that still goes to the nerves that control the bladder, even though we're stimulating the nerve in the ankle. Sounds kind of weird, but it works. So for patients who are not getting any better, we might, and I'm not going into a lot of detail on these tonight, but just to let you know that there are other options out there. Then there's Botox injections. Well, what does Botox do? So Botox calms the muscle down. So they use Botox in lots of therapies. They use it for cosmetic reasons. They'll use it, patients use it for migraine headaches. We actually even put it in the bladder for patients who are having severe incontinence that's just not controllable by other methods. This is a quick little video, if I can get it to work. So it's just talking about a normal bladder and what happens when you try to urinate. So you get signals from the nerve endings that go to the bladder. And when it's time to go, you're able to control it and you're able to go. In an overactive bladder, the bladder contraction occurs too early, so you can't hold it like you should. So your bladder fills maybe halfway, and then boom, you get the urge to go, and it goes. So these medications work on those receptors. Stress incontinence is leaking, as we said, with coughing, sneezing, that type of thing. What do we do for stress incontinence? Physical therapy first, and then we may recommend some type of surgery or an injectable agent. What are the risk factors for incontinence? Age, pregnancy, how many children have you had? Vaginal delivery versus a cesarean section. Weight, prior surgery, smoking history, family history. Patients will say, oh yeah, my mom had the same problem. Diet, and maybe other medical conditions. Non-surgical treatments, again, physical therapy. I'm a huge believer in this. Bladder retraining, prompted voiding, perhaps not waiting too long to go. Surgical treatments, the most common surgical treatment right now for stress incontinence is called a sling. And gynecologists do it, urologists do it. A Birch procedure is not done so much anymore. It was a very common surgery many years ago, but probably the most common procedure now is a sling. No medications are currently available to treat stress incontinence. This slide does not talk about bulking agents. That's another thing we can do. We can inject, we used to inject collagen. Now there's a couple other newer products that we can inject into the urethra just to make it a little tighter. Those I think, are not as long lasting as a sling, but they're a good option for someone who doesn't want a bigger surgery. Urinary tract infections, probably several of you have experienced this. Symptoms of infection are pain, cloudy urine, odor to your urine, going more frequently. It's usually caused by bacteria from your intestinal tract. It's more common as we age, often due to lack of estrogen, and it can be related to sexual activity. How to treat recurrent urinary tract infections? Well, an exam is important to make sure that you're emptying your bladder completely and to rule out any other prolapse issues or physical issues. You need to get a urinalysis and a culture. And then we treat based on the culture. We give people culture-specific antibiotics. There are some medications that can help prevent infections. There's some urinary acidifiers out there, meaning they lower the pH of the urine. Vitamin C will do this in combination with a medication called methenamine. Sometimes cranberry can help, certain cranberry supplements. Elura is a particular product that it's a higher dose cranberry than you can buy over the counter. It's mail order. It's kind of expensive is the only problem. It's about $1.50 a pill. We also recommend D-mannose, probiotics, and then we'll start some of our women on some type of vaginal estrogen because when menopause happens, your pH of the vagina changes due to lack of estrogen, and so some of the bad bugs want to live there instead of the good bacteria. So we're trying to restore the normal pH of the vagina and the normal bacteria. And then for some patients, we'll do imaging, an ultrasound or a CAT scan, or we might look in their bladder. So what is prolapse? There's different types of prolapse. You might hear these terms. A cystocele means prolapse of the bladder or the anterior compartment of the vagina. A rectocele is a prolapse of the bottom part of the vagina. And then there's uterine prolapse, which we don't deal with as urologists. I don't deal with uterine prolapse, but gynecologists would do that. So some women will need a hysterectomy for that. And then sometimes after a hysterectomy, you can have something called total vaginal vault prolapse, where the whole vagina is prolapsing. And there's some very specific and high-tech surgeries to fix that. That's what Dr. Parrillo specializes in. Treatments for prolapse, you might benefit from a pessary, which is like a diaphragm. It's like a round, I tell people it's a kind of a round disc-shaped tampon that just holds everything in place. And then there's surgical treatments if you need to have it done. You don't necessarily need to have surgery for prolapse. It depends on if it's bothering you or not. If it's not severe, it's not bothering you, you don't necessarily need to have surgery. It won't kill you. It's annoying for some women, but you don't always have to have surgery. So other things that gynecological issues after menopause include vaginal dryness, and that's kind of why we're here, mainly to talk more about new options for that. Prolapse, as I mentioned, lack of desire, urinary tract infections. We start a lot of women on vaginal estrogen, and there's different forms. Creams, which can be inserted 2 or 3 times a week. Sometimes they're messy and expensive, but we use a lot of them. Estrogen can come in the form of a suppository or tablet. There are rings that have estrogen, and they're used once every 3 months. You take a ring out, put a new one in. And then you just need to be consistent with it. That's the downside of using estrogen. You need to be consistent and keep up with it.
Become yourself again with MonaLisa Touch. It's okay to talk about it. Gynecologic health is an important aspect of a woman's overall well-being. When estrogen levels decline due to menopause, women experience changes in their gynecologic health. And studies show that only 25% of women seek help from their doctor. Now with MonaLisa Touch, there is a treatment to address these changes. This procedure has been described by patients as life-changing, and they want to talk about it. A large portion of postmenopausal women and women treated for breast cancer or induced menopause are experiencing changes in their gynecologic health. The MonaLisa Touch offers a non-surgical approach to deliver lasting relief that is typically noticed after the first treatment. MonaLisa Touch offers women a new therapy that has minimal side effects, no downtime, and lasting results. It's time to talk about it because now you can do something about it. Patients typically describe MonaLisa Touch in 2 words: simple and safe. How does MonaLisa Touch achieve these results? Similar to your yearly exam, a probe is inserted into the vaginal canal, a gentle laser is fired, and a pattern of microablative wounds target the vaginal tissue. The injury triggers a wound healing process that causes revascularization and increases in collagen in the vaginal mucosa. The therapy requires 3 treatments, each lasting less than 5 minutes. Because no anesthesia is required, and it is done in your doctor's office. The best part? No downtime and virtually no pain or side effects. When women are experiencing changes in their gynecologic health, being treated with the MonaLisa Touch may positively impact their overall health and also their quality of life. MonaLisa Touch has been successfully treating women since 2012 and delivering results that have been overwhelmingly positive and immediate. The MonaLisa Touch difference allows you to feel better with no downtime and minimal discomfort, which is important to you and your doctor. With MonaLisa Touch, it's not only okay to talk about it, it's okay for you to talk about it too. Talk to your doctor today about MonaLisa Touch and become yourself again.
So the MonaLisa laser is sort of probably the big reason why you all are here tonight. It's a fairly new treatment. It is laser therapy. It's a carbon dioxide laser therapy that was approved by the FDA in 2012 for the treatment of postmenopausal kind of vaginal issues. So it's approved for pain with intercourse, vaginal dryness, vaginal irritation. There are some very early studies that are showing perhaps some improvements with some of the urinary symptoms that women experience after menopause, but unfortunately it's just a little bit too soon. We don't have good evidence for that, and so we can't say that we expect improvements with that. We hope so, but we don't really know for sure that that's going to pan out. Basically, the way this device works, it is intravaginal probe that's inserted, and then we kind of laser along the length of the vagina, and then there's also an extravaginal laser treatment as well. It takes about 15 minutes in the office. There's no anesthetic or anything like that. We do use a local numbing cream on the exterior aspect, and that gets wiped off. Unfortunately, we can't use any sort of lubrication or internal numbing gels. The laser just doesn't work if you have any sort of interface between the tissue and the laser. It's 3 treatments. They take about 15 minutes each. You go home right afterwards. We have you use cold compresses and Aquaphor, some sort of, or Vaseline, some sort of lotion to kind of treat the external area. And usually that ends up lasting for about a year. We are finding that women do need maintenance therapy where they come back annually for a retreatment, but it's just one retreatment after that. Approximately 90% of women say that they feel significant improvements in terms of the pain with intercourse, the burning, the dryness, the itching, the irritation afterwards. And 60 to 70% of women say that they feel normal. So the way that this laser works is it uses carbon dioxide to place small, little, teeny, tiny microscopic holes in the tissue of the vagina. That causes the breakdown of collagen, which then causes new blood vessels to come in. The new blood vessels come in and your body naturally rebuilds collagen. I hate the term vaginal rejuvenation. I don't think that's an appropriate term to use. We can't make vaginas what they were when women are 20 or 25 or 18. But the idea is that we can help rebuild your tissue so it's more normal, so it's thicker, so it's healthier, so it kind of secretes its own fluids again, and so people are more comfortable. And it works, and it's a great thing to be able to offer. I think probably both Dr. King and myself, estrogen has been our only option for years and years and years with women, and like Dr. King said, it is messy and expensive, and you do have to use it every 2 to 3 days, and just the opportunity to use a laser treatment a couple times in the first year and then once a year afterwards, it's really exciting. This is just a picture of the internal device. So it basically is just a metal laser that is inserted, and then we sort of laser every centimeter of the vagina in 6 different places, and then again, there we go, treat externally afterwards. And so that's sort of how the laser works and how we expect to use it. I'm just going to close this now so it stops talking at us. There we go. No, I don't think so. And so in terms of, if you are interested in this, what we'll have you do is come in and see us in our clinic. We do need to do an exam. There are a couple situations that would make women not eligible for the laser treatment, and that only way we can tell is if we actually do an exam. And then we have you come in the day of treatment, we have you shave externally, we apply the numbing medication, do the treatment. About 15 minutes later, you should be going home and able to go about your normal life. We do ask that you don't exercise heavily for a couple of days, no intercourse for a couple of days afterwards. But really, there shouldn't be any significant downtime with the treatments. And so that's sort of the basic way it works. Do you all have any questions? I was sort of hoping this would be a dialogue. Yes?
Is there an issue for patients on warfarin?
So it's one of those things where we would have to make a personal decision about it. It's not recommended that people be on anticoagulation with treatment, and so we would have to discuss together if we thought it was a good idea. Yes, ma'am.
What are the costs?
So we're currently having a special at and it extends through the end of April. For the 3 initial treatments, it's $1,500. Beyond that point in time, it's regularly $2,100, and the maintenance is around $700. Unfortunately, right now, this is not covered by insurance. I am hopeful that it will be in the next couple of years, but insurance companies sort of do what they like, and we have no control over that.
But you can take it off taxes, though.
Yeah,
You can take it off taxes,
you should
though.
be able to.
Yeah, you can.
Yes, ma'am.
How long between treatments, between the first?
6 weeks.
6 weeks.
Yes.
How long have you all been doing it?
So this is brand new to us. I went to LA to get trained on it. We've done a couple in our clinic, but it is something that we're just adapting to our practice here. Yes.
If you've had NovaSure before, is that effective at all?
Shouldn't.
It shouldn't.
No.
When she has
NovaSure, if that affects it. Any other questions, concerns? Yes.
what are the risks?
So, it's a laser, and there are inherent risks with the laser. I think that if you use it properly, according to the recommendations from the company, the chance of serious laser side effects, like big burns or something like that, are pretty much non-existent. I think the only way that would happen is if you're really using the laser inappropriately, which neither of us would ever be inclined to do. I think the biggest issue is probably discomfort with the insertion of the probe. Like I said, we can't use any lubrication, and so that seems to be what most people complain about in the studies. And then afterwards, a little bit of spotting, maybe a little bit of discomfort in that first day or so, a little bit of vaginal drainage. For the most part, patients don't seem to feel much with the actual application of the laser. They describe it as like a fluttering or a tingling sort of feeling internally. Externally, because we have applied the numbing gel, I don't think people feel anything really at all. Yes, ma'am.
How big is it? What kind of diameter?
Oh, that's a great question, and I don't know off the top of my
It's
head.
really not
It's-
that big, and it's not that uncomfortable. It's
Yeah,
pretty small.
It's pretty small.
Pretty small.
I would say maybe 2 to 3 centimeters across.
I don't know if any of our slides talk about it. I was just seeing if,
Quarter size?
I think it's smaller than that.
Um,
A little bit smaller than that. Yes.
When did this procedure come out?
So it was FDA approved in 2012, and so it's been going since then. It started in Italy, actually, and it has sort of taken a little while to make its way over to America. Yes, ma'am.
I couldn't hear you
Yes.
about your special.
Oh, I'm sorry. So it's $1,500 for the initial 3 treatments if you come in before the end of April instead of around $2,100. Any other questions? Yes.
Do you need to continue to use estrogen creams afterwards?
So in theory, no. It's interesting. There's one clinical trial that compared just estrogen to just laser therapy treatment to combination of laser therapy and estrogen. And there does seem to be maybe a little bit of added benefit if you keep using the estrogen, but it's not really significantly different from the laser therapy. And so I think probably, the goal is to get you off of that, and that's what we're hoping to do.
Would it revascularize scarring?
Hopefully, yes. It would sort of depend on your individual exam and what things looked like. I think if you had a ton of scarring, we can only get so far with any of these treatments. But if you have some healthy tissue and a small amount of scarring, I would expect you to do well with it as well.
So it's 1,500, does that include the initial first coming in and seeing the first appointment?
I think so. You know? Yeah, I don't know.
That's a really good question.
That's a great question.
So how much is your first?
The
is it
consultation.
usually?
I mean, that would.
And will that be covered by insurance?
So that would be covered by insurance because it would just be a consultation with a physician if it were not part of the $1,500. So it would be a copay at most.
Dr. Parrillo, can you address the breast cancer, like to the
Yeah. So women with breast cancer often can't be on estrogen. Also, women who have a family history of some clotting disorders aren't supposed to be on estrogen. And this is one of the reasons I'm most excited about this product because we just had nothing else to offer those women in the past. But they're totally great candidates for the MonaLisa. And so if you have a history of either of those things or have any family members that have a history of those things and they haven't been able to be on estrogen previously, have them come in and talk to us because they can get this, finally. Any other questions? Yes, ma'am.
I'm always skeptical, this almost sounds too good to be true.
I know.
So can you kind of address that, like,
I mean,
how could this be, it seems like a miracle.
you know, it's one of those things where everybody has different levels of improvement. And again, I think it's important to understand that we're not going to make you 18 years old again. But women do, and the majority of women with the treatment do seem to have significant improvements where they feel that not only do they have less pain with intercourse, but they're able to have intercourse more often, and intercourse is more enjoyable. Will you be wanting to engage in intercourse every night of the week? Probably not, but hopefully it would be better to be able to do it more often, which is the goal. Yeah, it does seem a little bit like a miracle, but it is working, and the data, though early, is good. And so I think we're both pretty excited about it. Yes.
So are the results similar for the urinary problems as well as the
So-
dryness?
So thus far, with the way that we do most clinical trials is we sort of have almost observational studies. They're more subjective at first. They're not random controlled where patients don't know what they're getting. And so that's what's happened with most of the urinary symptoms thus far is the data is all subjective. Women saying, yes, I feel like I don't go to the bathroom as often, or my urgency is less, or I leak less, but we don't have any good data yet that's really scientific in terms of it being objective. Yes.
So, okay, I just first want to say, she didn't hire me to say any of this. She doesn't know me, but I've had MonaLisa done. I had it done 3 years ago, the 3 treatments. I lived somewhere else. And the reason I came tonight is to find out because I actually just in January, I flew back to California to have my touch-up for my 1 year, this is the 3rd time I've had it done. And it really does work. So anyways, that's why I came. And it actually helped me as far as when I sneeze, I don't put my pants anymore. And or when I cough, so it did help that. It's really not uncomfortable. Having a pap smear is way more uncomfortable than having MonaLisa Touch done. So anyways, I just wanted to say that I can say that it works. It worked for me.
I appreciate that.
Yeah, and it really does make it not so, after the first treatment I could tell there was a difference. And like the doctor had said when he looked down there, he said what happens is that it starts atrophying down there and it's like a lighter color, which sounds really gross. But anyway, so that's what's happening after the first treatment. He said it actually is looking like, your gum colors, like it's pink again, like it's supposed to be because it started regenerating the fat growth. And then by the 3rd time, I just felt normal again. So, and I can't take estrogen, so that's why I had to do it. So anyways, I just want to say it has worked for me. And it sounds like it's almost too good to be true, but it really does help.
And
a lot.
Every woman I've met who's been through it has great things to say about it, that it's worked for them. I just unfortunately can't make you any promises when it comes to the urinary symptoms because We just don't have the data yet, but a lot of women are reporting really positive changes with that as well. Yes.
Yeah, I have a total hysterectomy, and I was placed with the highest dose of the estrogen. And at that time, I was experiencing a pus on my left breast, and my French is pretty good. I said, we don't use that in the Philippines. Why will you? I'll stop it. And I did stop it, honestly. I didn't ask my doctor or anything, but I went to see the breast, and the biopsy me, and if I didn't stop it, I probably have more cancer or something, because he told me just like the wart growing on my biopsy. So sometimes as well is the side effect that you have to kind of think about it like that. This is the highest dose that he prescribed me, and I didn't. It was yellow, because the highest one is the yellow,
Mhm.
the estrogen,
Okay.
and it's yellow coming out on my left breast. And I think it's always nice to kind of talk about it as well, because there's a lot of side effects of the things that we take.
There are, and someone like you would probably be a better candidate
Yeah,
for this
I
than
looked
the
at
estrogen.
King, kind of all the things that she put in there, because I have a total hysterectomy, and I'm very prone for urinary tract infection, and I was a patient of Dr. Klein. That's why I was so interested when I see this. He sent me a letter actually too.
So thank you for coming.
Well, thank you.
Yes, ma'am.
How long have you been doing this procedure, and have you had anybody with it didn't help at all?
So it's new to us. We've only been doing it for a couple months. And so it's just too early for us to really report that sort of experience. Like I said, I went to LA and I watched them, and I spoke with a bunch of patients that they had that day, and all of them were happy. I am sure, like I said, 90% of women feel better. That means that 10% don't. But the chances are that you will. And there's another trial that they did sort of looking at cost satisfaction, because I do recognize it's quite expensive. And almost 80% of women said that they were totally satisfied with the cost based on the results that they had experienced, which I thought was really telling and interesting as well. Yes, ma'am.
So, do like most, or what percentage of women experience atrophy, and about what age is that?
So we all do once we stop having natural estrogen. When we experience it kind of depends. Women who have surgeries early on that limit their estrogen production, or they have their ovaries out. I mean, I saw a 40-year-old this past week that has it, or much older. It kind of depends on when you go through menopause. Yes.
So have the studies proven anything about from the time you go through menopause to when you have this treatment done? If it's been 15 years or 5 years, does that make a difference?
It seems to suggest that women who are closer to menopause do a little bit better, and some women who are a little bit further out from menopause maybe need their retreatment sooner than those that are closer to menopause. They actually state that you can do that retreatment anywhere from 6 to 12 months afterwards, and the idea is that if you were to start experiencing a recurrence of your symptoms, we would want to get you in for a retreatment sooner rather than later, so we're not back to square one. Yes.
I think, in general speaking, 1,500, that's not expensive. Well, because like I went to the stem cell training like this, and introduce you, kind of tell you something that new they're doing it. Some of them, they said like 7,000 out of the packet. So I think the 1,500, I think that's pretty cheap. I mean, in general for me, I think, because I am on Medicare, plus I'm really very lucky because I have TRICARE for life.
Yeah.
So I don't have to worry about my coffee or anything like that, because I'm covered. Whatever the Medicare doesn't cover, the TRICARE for life will cover for me. But still, I go for training, some of this that they offer, and that's what I gathered from the like stem cell that they're gonna be doing it to people. Because like us, like we have knee, like me now, I am only 68 and I'm already have a problem on my knee, and that's what we're gonna introducing about the stem cell, things like that. I'm really going to spur me.
Yes.
Dr. Klein goes there.
We really researched this before we bought it because it's not cheap for us either to buy this device. It's pretty expensive, but there's other lasers out there, and the nice thing we like about MonaLisa is they only sell it to gynecologists and urologists. So they're not selling this to a spa. It's different from what you might get at a spa. I think it's a better laser, and it's being done in the hands of professionals and not just a technician. I have a good friend who's a urologist in Seattle, and she's been using the MonaLisa for a long time, and she loves it. She just loves it for her patients. So we talked to other clinics that have it. We talked. There's a clinic in Salt Lake that has it, and there's a clinic in Northern Idaho that has it. So we really did a lot of research before we bought it.
Yes. I think she just answered my question, but when you come in, it's one of you that does it, not a nurse or anything.
Right. Right now it's us. In the future, we might have a PA do it, but right now we're just doing it ourselves. So.
Well, I would recommend of the doctor. They have 2 more years training.
Yes.
So, does it have anything to do with health UTIs or not?
The data on that is still pending as well. There does seem to be some degree of change in the bacteria that naturally exists in the vagina afterwards. Whether or not that's going to long-term result in a not getting UTIs, we don't know yet. But it's interesting to see how the flora changes before and afterwards. And in my brain, it makes sense that it would help with it. Yes.
I know you mentioned that it helps with discomfort and dryness. Does it have any impact on the integrity of the vaginal wall from prolapse?
Do you mean like preventing prolapse from happening, or what do you mean?
Or is there any improvement in like the severity of prolapse afterwards if the vaginal wall change?
Probably not. So one of the reasons that you would not be able to undergo the MonaLisa is if you had severe prolapse. That's one of the contraindications for it. I think that I find that a lot of patients, even with a small amount of prolapse, feel better when they're on vaginal estrogen, and I think that has to do just with improved epithelium and more comfort. And so I think that would be the same with the MonaLisa Touch, but I don't know that we can't say that it would make things go back up, unfortunately. That would be a real miracle. I did that too. Yes.
So the fact that you guys are urologists and this kind of seems like a gynecological issue, what made you decide this is what you wanted to do?
Well, I specialize in both male and female reconstruction. That's what I trained in, and so I actually do a lot of pelvic organ prolapse and incontinence in women, and I'm pretty passionate about it. So I think that's why I have been looking forward to having this.
With her training with the gynecologist.
And we tend to see a lot of women with urinary tract infections after menopause. They don't go to the gynecologist usually. They stop seeing your gynecologist at a certain age. So we start seeing them. And then we order a ton of estrogen, probably more than the gynecologist, a ton of estrogen cream.
Yeah,
So,
I know. I
yeah.
haven't gone to a gynecologist for probably at least 10 years.
Yeah.
But I go with the urological.
But some gynecologists do it. There's a gynecologist in town that's been doing it for a while, I think.
Yes.
What are the complications associated with it, and are there some? What's the incidence?
So severe complications really low, like I mentioned. As long as you're using the laser properly, the chances of having any significant complications from a laser, like burns, are almost non-existent. It's really just minimal side effects that are temporary from the treatment, a little bit of discomfort, a little bit of drainage, not be able to exercise, those sorts of things. And again, what most people seem to complain about is the probe insertion, which gets better the second time and the third time around, but the first time especially is uncomfortable.
would you see someone who just has issues with urinary problems and would be willing to try it?
I think that would depend on your exam, and we would have to have a consultation and sort of talk through things. A lot of times I think we can maybe tease out things that you're not necessarily aware of, or we'll see things on your exam that you're not necessarily aware of that may make you a good candidate for this. Any other questions? Yes?
I've had multiple surgeries for vault and had the mesh taken out, and they've kept some of the mesh because I had other procedures to lift up the bladder. But I retain urine. Would that be a factor in helping release that? Or is that something you just have to go in and get consulted?
You'd have to come in, you'd have to talk about your previous surgeries and what you've had done, and whether or not that's to be a candidate.
But you can be a candidate for this if you've had just a sling, but I think they still say not if you've had bigger pieces of mesh in there. They're not recommending it.
For cervical pexies, you can have it.
Okay. There were some older mesh repairs with big kits and big pieces of mesh, and those kind of have gone away, so. But a sling is okay, and the cervical plexus.
So it would just depend what you've had in the past. Anybody else? Yes?
So what does this do to nerve endings? Are nerve endings involved?
I mean, I'm sure they are. Thus far, they haven't really talked about like increasing sensation or anything like that. I think mostly nerves are really tricky in terms of what happens to them, especially after they've been damaged. I think probably mostly it's just a less pain because you have better tissue and healthier tissue. Yes?
So I want to clarify, this is postmenopausal or during menopause? When is it best to have?
So it depends totally on your symptoms and what you're experiencing and your exam. And so if you are experiencing dryness, itching, pain with intercourse, that would certainly make you a candidate, whether or not you're perimenopausal or postmenopausal. Anybody else? Yes.
Yeah. How about like me, because I have a total hysterectomy and I don't take any kind of the estrogen. How about if I will ask Dr. Klein, or actually I booked one for you, but then you were out or somewhere, that's why I didn't get you, because I kind of like to see a female instead of the Dr. Klein. I like Dr. Klein. He's married and I know he's married.
We like Dr.
So,
Klein too.
And then with
He's
the
fun.
women, it's nicer to see, like me, since I lost my husband, I become more timid. And I asked if I could see one of the female, which is Dr. Parrillo. But then I think something happened that you were sabbatical. I don't know.
Oh,
Maybe that's when you were doing your training or
I
something.
apologize for missing you, but please come back and see me. I'm very happy to have you come visit with me.
And then I was going to ask if that, like if you take a lower dose of estrogen, maybe that will help for my, because I get a urinary tract infection. That's why I was in your office the other day. And
Let's get you set up to come see us, and we'll talk about your issues there.
Okay, thank you.
Any other questions? Thank you so much for coming, spending an evening with us. We really appreciate it.